Good evening, everyone, and welcome to You and Your Health. We are excited to have you join our program this evening. If you're tuning into the program for the first time, my name is Yvonne Puplampu-Dove, a co-host of this program. I have my other co-host, Dr. Edward Isuman, and Mrs. Irekwa Roberts Hilton. Hello.
Hi, Yvonne.
Hi, how are you?
Fine. Well, welcome back.
Thank
Welcome back. We
you.
missed you last week, and
Thank
we're behind. So I'm going to be quiet so you can go ahead with your program.
Awesome. Let's
See
get
you soon.
started. Our discussion today is on diabetic foot care. As we all know, diabetes is very prevalent in our society, and diabetic foot disease is one of the severe complications of diabetes, especially when the disease is not managed properly. Today, we are so grateful to have Dr. Gifty Ajiman with us to educate us on what the disease is, who is at risk to get the disease, and how can one prevent it. Dr. Giftia Jiman is a first year resident completing her preliminary year at Mesta, Baltimore. She will be continuing her residency at the Johns Hopkins Hospital in anesthesiology. She completed her medical education at the George Washington School of Medicine and Health Sciences in 2021, where she was inducted to the Gold Humanism Honor Society, the value that values the human connection between physicians and their patients. Prior to that, she spent 2 years as a research fellow studying tumor microenvironments in glioblastoma, a fatal brain cancer. She graduated with high honors from Abilene College and Conservatory in 2015 with a major in neuroscience and a minor in Africana Studies. In her short professional career, she has 11 publications, numerous presentations at conferences across the country. One of Dr. Jiman's greatest motivators is her passion to serve her homeland, Ghana. She takes pride in her identity as a Ghanaian American, and she hopes to return home to make an impact in the place that made her. We are extremely appreciative to have her join us this evening. Let us welcome our guest, Dr. Gifty Ajiman.
Hello.
Hello, Dr. Jiman. Welcome. How are you?
Oh, thank you. I'm doing well. How are you?
I'm doing well by God's grace. Thank you so much for joining our program.
Absolutely.
For our viewers, please be sure to enter your questions in the chat. We have a lot to get through, so without further ado, I hand things over to Dr. Jim and Doc. Please take it away.
Thank you, Dr. Yvonne, for that great introduction. I wanted to just give a disclaimer that I'm not an endocrinologist, which is a doctor that studies and treats diabetes regularly, but I have had some great experience and would like to share this because it's important with our community. So let's take it from the top. The title of this presentation is Diabetic Foot Care, a Matter of Life and Death. Next slide, please. So just briefly, I'll give an overview of what we'll be talking about today. I'll give an introduction, give some general information about diabetes, what it is, and specifically type 2 diabetes is what we'll be talking about today. And then I'll get into detail about the foot disease and why it's so important for us to manage diabetes well in order to prevent the foot disease. I'll talk about how we can better manage it, some complications, and some poor outcomes when you have poor management as well. And then we can end with a summary and some questions. So a lot of us have heard about diabetes. We have a general understanding of what it is, but it's really amazing to look at how much it impacts our world. In the United States, there's about almost 40 million people who actually have diabetes. That's about 11%. So you would imagine, let's say in a group of 10, one person would have a diagnosis of diabetes. Um, Also importantly are those who don't get diagnosed for different reasons, maybe poor access to healthcare or just not really understanding the diagnosis or the symptoms that they were having. In addition to an actual diabetes diagnosis, there are many people who have something called prediabetes. So the way in which we determine if someone is a diabetic is we use a value called a hemoglobin A1C. You may have heard that from your doctor's office. And certain level of hemoglobin A1C is an indicator of whether you have diabetes or prediabetes. You can imagine that almost 100 million people over the age of 18 have been diagnosed with prediabetes, which generally moves forward to become fulminant diabetes. This is really important in our community as Black people. So this study was taken from a paper where they looked at the genetic risk of getting diabetes among different types of people. The green dotted line is representative of people of East Asian descent. That purple line is representative of people of American Indian descent. The red dotted line is representative of people of European descent. And that blue dotted line is representative of people of African descent. As you can see on the bottom, oh, let me please go back. On the bottom of the graph is the genetic risk score. And the higher the score, the higher the risk of or having diabetes. And you can see that the blue line is the furthest along the x-axis, or that bottom line, which suggests that people of African descent have a higher risk, a genetic risk of actually having diabetes. So what exactly is diabetes? It's basically a disease where your blood sugar or blood glucose is poorly controlled and often too high. Your blood glucose is the main source that your body uses for energy. All of your muscles use it, and it comes from the food that you eat. There's a hormone in the body called insulin, and it's made by our pancreas. Many people don't even know what the pancreas is, but it's one of the most important organs in the body. And what it does is when you eat your food, your rice, your stew, your fufu, all of that, it takes the glucose from it and helps your body to use that as energy. Now, insulin is actually the reason why people get diabetes. Because if your body doesn't make enough insulin, like in type 1 diabetes, or your body does not respond to the insulin it's making, like in type 2 diabetes, you can't get that glucose into your muscles, sits in your blood, and it can cause a lot of issues. So here's a quick diagram of the different types of diabetes. On the far left of your screen, the representative of what I just said is healthy. You eat food, your stomach digests it, your pancreas releases insulin, and that allows the glucose in the food to get to your muscle. That's how it should be in those of us who do not have diabetes. Type 1 diabetes, which primarily affects children, is when you have the food, you eat it, but your pancreas no longer makes insulin. So what happens is that glucose doesn't go into the muscle, and it can sit in the blood, lead to very high blood sugar levels, and even at times very low blood sugar levels if you don't eat enough sugar. Type 2 diabetes, which is where I'm going to spend a lot more time talking about today, because it usually has the complications of foot disease, is when you eat food and your pancreas can make insulin, but you have receptors in the muscle that are not accepting the insulin, and therefore there's no way for the glucose to get into the muscle. So you end up with very high amounts of sugar. And for those who may have been diagnosed with diabetes at some point, sometimes they find out by having blood glucose levels in the very high hundreds and even thousands, when an average person would have a blood glucose anywhere between 60 and 100 or 120. So there are several complications of your body having all of this, let's say, sugar in the blood. You can imagine if you were drinking a glass of water, very refreshing water, and somebody dumped a whole bunch of sugar in it, it wouldn't have the same outcome that you would think on a hot day. So what happens with diabetes is very similar. Some of the complications include heart attack, arterial disease, even diseases of the eye, includes having kidney issues, and even some leading to complete kidney disease requiring dialysis or kidney replacement. Sometimes the sugar or the glucose can deposit and cause nerve damage, and that's often seen in diabetes. And one of the scary complications of diabetes is stroke, because that same glucose can get into the blood vessels of the brain, affect the vessel walls, and make it difficult for you to get blood to areas of your brain. But we're going to talk today about diabetic foot. So what exactly is diabetic foot disease? So unfortunately, the feet are the furthest thing from the heart, and the heart is what pumps all of our blood and keeps everything working the way it should. And so the feet often become a target in diabetes because of that already naturally more poor blood flow. What happens in diabetic foot disease is that you usually have something called a peripheral neuropathy, which is nerve damage of the nerves furthest away from, let's say, your brain. So it starts in your toes or fingertips. You can also have something called ischemic disease, which is poor blood flow, and that can lead to death of the muscle and the tissue in your feet, and that can cause a disease called gangrene. Diabetic foot ulcers are things we see all the time in the hospitals because they're actually quite painless ulcers, and people don't know that they're getting them because of that neuropathy. And then those ulcers can progress to infection of the skin, the tissue, and even the bone, which we call osteomyelitis. Interestingly, you also have diseases where the joints of the feet can become awkwardly shaped or rounded because of the abnormal pressure on the feet that people with diabetes can't always feel because of that neuropathy. And I have a picture here on the right of what we call Charcot foot, which is basically the abnormal curvature of the joint due to the peripheral neuropathy. So you can see in this x-ray here that the person's foot has over time become rounded at the bottom. And that's just because they can't feel the damage that's happening to the joint because of all of the peripheral neuropathy. Now, diabetic foot ulcers are often caused by high levels of glucose that begin to saturate and deposit into our smaller vessels. It causes damage to those vessels and can eventually lead to poor perfusion of the nerves, meaning that the nerves in that area are no longer going to get blood either. And so what happens is you have poor feeling in your feet. A lot of people with diabetes, if I were to tickle their feet, they don't even know that I've touched them, especially if their diabetes is poorly managed. So with these ulcers, what happens is if you have a rock in your shoe, or maybe you wear an uncomfortable shoe for a long time, your foot is getting damaged, and where maybe I would be able to say, oh, this shoe is not comfortable, it's giving me an issue, it's giving me a cut, giving me an ulcer. Sometimes with diabetes, people don't feel that, and it leads to some very dangerous outcomes. Here's a diagram of what we call a dysvascular foot. So a foot that is not getting adequate blood flow in the setting of diabetes. We usually grade them from 0 to 5, and grade 0, as you can see, is just an area of irritation. What happens over time is that area of irritation becomes an area of superficial ulcer, meaning that it's just something on the very top layer of the skin. That then progresses to a deep ulcer, which can then eventually become an abscess osteitis, so inflammation of the bone as well. And here's a picture of what I mean by gangrene. Gangrene is when the tissue of the foot dies, or any tissue in the body dies. So you see that it turns black like that because it's essentially rotting. And when it gets to grade 5, this is essentially the entire foot has died because it no longer has any blood flow. Here are some images of what a diabetic foot ulcer may look like. There on the far left of your screen is maybe a grade 1. And then as you progress into the middle image and the further image, you're getting more to a grade 2, grade 3. And the last image may even be getting more to that osteitis, is getting deeper into the tissue. I hope nobody is eating while watching this presentation, because some of these images are a bit graphic, but this is what diabetes can do to your foot. What happens over time, especially if people have poor management or poor follow-up with medicine, is that their foot just continues to die. You have poor blood flow to these areas. And you can see that it doesn't always start in just the toes. That first image, this person likely had some sort of cuts or ulcer that started because of maybe a poor fitting shoe, or they had a fall. And because of that poor blood flow, they're not able to get the necessary cells to that area to heal the wound. So a lot of times you have these very poor healing foot wounds that can become infected, and that can lead to a lot of complications in the future, which I'll go into detail. This is one complication that often happens in people who have poorly managed diabetic foot disease. So what you see on the left in the picture of the foot just looks like an open wound, something that could probably be cleaned and put back together. But the x-ray is actually showing there in the big toe that there's an area of the bone that is breaking down. This is called osteomyelitis, where you have an inflammation or an infection that started in the tissue and has burrowed its way down to the level of the bone. And what this does is it essentially causes bone disease. Osteomyelitis is difficult to treat because your bones are not very easy to get medication into. What happens is this osteomyelitis, if not properly treated, can become chronic osteomyelitis and can lead to long-lasting bone disease in that area, which may require that whole area to be cut off in an amputation. So why is diabetic foot disease a matter of life or death? From this paper, it shows us the complications of different diseases and how long people live, or the percentage, I'd rather say the percentage of death after 5 years. So let's take a look at breast cancer. By God's grace, we've made so many advances with breast cancer. And so in 5 years, a person with breast cancer may only have about a 10 to 15% mortality, or 10 to 15% chance of dying. On the very far end is lung cancer. Lung cancer is very fatal. And people with lung cancer in about 5 years have a 75% of dying. But you can see there in the middle, a lot of picture of feet. For instance, I mentioned earlier about the Charcot foot, and about 25% of people who have Charcot foot will die in 5 years. Same thing with the diabetic foot ulcer. About 25-30% of people will die with having this complication in 5 years. And then if the foot disease gets as bad as needing to be cut off, like in a minor amputation or in a major amputation, you can see that people have over a 50% chance of 5-year mortality. That means 1 in 2 people who have an amputation as much as maybe above the knee or after a diabetic foot disease will die. That's 1 in 2 people. So it really is important that we take excellent care of people with diabetes so that they don't even get the foot disease in the first place and put themselves in a position to essentially not have a very good outcome. So what are things that we do? A diabetes management is, it has a whole realm of medicine in and of itself. People who study just diabetes, because of how prevalent it is and because of all of the advancements that are being made. General diabetes management is to manage the blood sugar. We use several medications like insulin, metformin, and even newer medications that do what they can to keep your blood sugar at a healthy level, keep your insulin at a healthy level, and avoid all of these deposits of glucose into the blood vessels. But let's say you end up having this issue where you have glucose depositing into the vessels, where you have risk for diabetic foot disease. We have different medications like aspirin or Plavix, also known as clopidogrel, which we call antiplatelet agents. They allow for your blood to be a little bit thinner so as to not form clots and to not lead to that ischemic foot disease. Another thing that we usually give for the neuropathy are different medications that help reverse that loss of sensation in the feet so that you can have a better chance of feeling when your foot has an issue. And it doesn't go on as long as someone who maybe has pretty bad neuropathy. Of course, if you do have a diabetic foot ulcer that becomes infected, antibiotics are the way to go in terms of medication treatment. And the level of antibiotic that you'll need depends on the level of ulcer infection that one has. However, if it gets to the point where medications can no longer control the spread or control the infection of a diabetic foot ulcer, surgery is the next step. So for smaller wounds, smaller areas that can be cleaned, we usually have surgeons who will do something called a debridement. Basically, they'll cut out that dead tissue, that gangrenous tissue, so that the area that's clean and healthy can come back to heal itself. Basically, after cutting, they pack it up, and then essentially we wait, and time will do. Your body will do what it's supposed to do over time. Now, for larger wounds and larger areas, sometimes a safer option is to completely remove the limb or the area that's infected. Unfortunately, in the population that I serve, I see a lot of patients who come in with amputations because of diabetic foot disease. In fact, I'm usually surprised when I have a patient who has diabetes and has all 10 toes, because the toes are usually the first things to go. You can see in this image here on the left that this person has to get their second toe amputated, likely because of a diabetic foot ulcer that spread to osteomyelitis or became gangrenous. And then on the right is just an image of somebody who has to get an amputation above their knee, which is a large amputation. And so it's a very painful process. And it is debilitating in that we're so used to walking on two legs, and people who usually get amputations like this have a lot more hospital admissions, because in populations where this is prevalent, they usually didn't have very good care in the first place. And amputations require a lot of attention and a lot of care. And I often have patients who don't have that, and they return to the hospital with infections of their stump, with different pain disorders in their stump, and just with generalized weakness and inability to do things. So what are you going to do, or what are you going to tell someone to help them prevent diabetic foot ulcers? So like I mentioned, the most important things is to manage your diabetes. Keep that hemoglobin A1C level as close to normal as possible, and prevent high levels of blood sugars. Exercise is key, because as your muscles work more, they take in more glucose, get more out of the blood. For every condition out there, you should always stop smoking. And weight loss is also important in this process. Now, one thing that people with diabetes have to do is to inspect their feet and to wash their feet daily. This is to look for small stones or just anything in the foot. I mean, something as small as a little pebble that wouldn't bother anybody else. And someone who has diabetes can sit against the skin for so long that it leads to an ulcer. So daily feet washing and regular inspection. And then it's imperative that one avoids walking barefoot, so as to not step on things, so as to not get cuts to the foot because of that poor circulation. And then make sure that if you are wearing shoes that are too tight, or your shoes, you wear outside, avoid any sorts of rocks or stones in them by cleaning out your shoes before you wear them. It's important that you see a doctor or a podiatrist, because you should get regular foot exams. Every 3 months, a person with diabetes is supposed to see their doctor to check their hemoglobin A1C. And at that appointment, they should do something called a microfilament test. Basically what it is, a monofilament test. It's basically they take a very thin needle. The needles are of different sizes. They're not painful needles. They're very soft and they bend. But you should be able to feel the needle touching different parts of your foot. And in the exam, depending on the needle thinness that you can feel, it gives us an idea of any nerve loss that you may be having. So someone without diabetes may be able to feel the very thinnest needle on their foot, and maybe someone who has gotten some diabetes, neuropathy, or nerve damage may not be able to feel that very thin needle. They may require a more thicker needle, and it just helps us to keep track of any nerve damage. Of course, that's when you have someone to look between your toes. I know people don't like to look between toes, but it's important in diabetes to check between your toes. Looking for any ingrown nails. It's so one of the scariest things is people who cut their own nails in diabetes, to cut your own toenails. Because if you end up with an ingrown nail, which gets infected, anybody's ingrown nail can become infected. And a person with diabetes, it can lead to them losing their foot. So check for any ingrown nails, and then also checking for things like range of motion in the ankle. How much can you bend your foot? Do you have any weird shape to your foot that would lead to abnormal pressure? That could lead to an ulcer. So those are all the things that we would do in a diabetic foot exam. And there are important things to avoid for those who do have diabetes. Shoes that don't fit. That means, ladies, if your heels don't fit, don't wear them. Don't allow yourself to go through that process. It can lead to very poor outcomes. Don't cut your own toenails. In fact, there are podiatrist office or doctor's office where they will cut your toenails for you in a way that prevents ingrown nails. Do not use hot tubs. There's a lot of infection in hot tubs, and if you have any sort of diabetic foot disease, it can spread very quickly. Any sort of standing water, if you go to rivers or ponds and do some fishing, try to stand outside of the water and doing any of that. Walking barefooted is ill advised. Just get some slippers, some chalewote when you walk around, and don't use. I know this is tough because I love a pedicure, but if you have diabetes, you gotta avoid the pedicures because a lot of times it is a shared foot tub that people use, increased risk for infection. And if you already have poor circulation to the foot, that is something that can lead to a diabetic foot ulcer. Most importantly, go see your doctor. Um, Everything that I'm saying today will be repeated at a doctor's office. A lot of this can be found online, and it's important that you have someone to track and to keep track of your diabetes so that you can prevent this fatal outcome. So just a brief summary of what we talked about today. Diabetes, in essence, is just a disease where your sugar is not regulated, whether that's too high or too low. What happens is it deposits these glucose and other molecules into the blood vessel walls and can lead to damage of several organs, including the feet. And a large amount of foot disease or a large amount of diabetes complications do involve the foot. We know that poor management of one's diabetic foot disease can cost life and limb, literally, and that it's important to avoid injuries and infections to the foot for someone who has diabetes. Please check your feet regularly, that's daily, and also see a doctor frequently, at least once every 3 months, for proper management of your diabetes and any possible foot disease. So it looks like I went through that pretty quickly, but if anyone has questions, we're more than happy to answer some.
Awesome. Thank you for that wonderful presentation. Dr. Eddie, do we have any questions in the chat?
You're on mute. You're on mute, Dr. Eddie, if you can hear us.
Oh yeah, not yet. I'm now going through my text messages to see if I have a personal question.
Okay, awesome. I have a question we can start with. So you went through the different grades of the foot ulcers, and the color coding went from like a normal foot color to like a black foot. So on that grade, on that scale, at what point can you reverse the damage?
So once the foot becomes gangrenous or starts having dead tissue, it's irreversible. we know that only Jesus can raise the dead. And so once the foot dies, it is dead, and it has to be removed. That area has to be removed so as to prevent spread of the dead tissue. So I would say up until that point where you still have viable or tissue that's alive, it can be reversed, whether that requires surgical debridement. So like I said, they kind of scoop out any of the infected areas and then hope the skin kind of closes back together. Up until that point, you can still, I would say, salvage the limb.
I have a question. You mentioned pedicures. One would assume that, diabetics do get dry feet, right? In reading this, I found that you can't actually soak your feet. Just like you say, you can't walk and stand in water because it makes it worse. But they get dry feet, and some of the recommendations people will give them will be to make sure their feet has lotion on them. That they have diabetic creams that it could be used. But at the same time, putting creams and oils could also cause infection. It could cause moisture and infection. So I'm just curious as to what is the balance, because you will have the dry feet. You do have to kind of keep it moist, but then that could also be a problem.
Yeah. So I think to answer that, we have to answer why one can't have dry feet in diabetes. And when the foot is dry, sometimes you have flaking of skin, but even worse, you can have cracking of skin. And if the skin is to crack, it leaves room for bacteria to get in, either from your shoe, from the ground, or from wherever. So that's why it's imperative that the foot stays moisturized. Now, soaking your feet for someone who doesn't have diabetes is a great way to get moisture into the foot. But for those of us who have intact skin, we have a barrier against bacteria. Once your foot cracks, your barrier is lost. And so whatever's in the water, whatever's in the creams, becomes essentially a way to get into your body and can lead to infection. So when it comes to moisturizing your feet in diabetes, it's actually important that one uses more direct moisture. So there are creams that are made for patients who have diabetes. And it's a moisturizing cream, but it also acts as a barrier. And so it can not necessarily prevent bacteria, it's not that type of barrier, but it helps keep moisture from whatever cream you use into the foot, thus decreasing how much you have to use regularly. So this is not the person who's lotioning their feet every 20 minutes, but to lotion your feet after a shower is great because your foot is already moistened from the water. And if you use any sort of barrier cream, things like Aquaphor is a good option. It helps keep some of that natural moisture in, preventing you from having to use a lot of external moisture. But I would say soaking feet is absolutely a no. I would prefer to use lotion. I would prefer to use cream.
Okay.
Interesting. And you did mention during your presentation that diabetic foot disease and ulcers are more prevalent or common in type 2 diabetes. So does that mean that it doesn't occur in children with type 1 diabetes, or is it just rare?
It's definitely more rare in type 1 diabetes. A lot of times with type 1 diabetes, the issue is you don't produce insulin. So these people often have very, very high spikes of very high sugar and very low sugar. Whereas in type 2 diabetes, they produce the insulin and don't respond to it. So a lot of times their sugar just stays very high because they can't, their body is making the insulin to regulate it, but it's not actually getting into the tissue. So the diabetic foot disease or any sort of the complications of diabetes can happen in both type 1 and type 2 diabetes. If you have very high blood sugar type 1 diabetes, it can lead to deposits of the glucose in the vasculature, the eyes, the feet, the kidneys, but it's just a lot more rare in that particular type. Whereas in type 2 diabetes, it's far more prevalent and it happens a lot faster as well.
Right.
So,
And is it,
go ahead, Yvonne.
no, go ahead.
I was going to say a follow-up question to that. I was just curious as to whether it matters in terms of age. So whether it's like type 1 or type 2, if the patient is, let's say, under 40 versus a patient that is 65 years old, does it make a difference in terms of getting this disease?
Yeah, actually, because as we get older, our vasculature naturally our blood vessels naturally become less, they do the job a little bit less. So our blood vessels, they stretch, they move, they help blood get through them. But with age, we lose a lot of that natural stretch, and it's normal. It's not like any particular type of disease. That's why as people get older, you can see that they'll have hypertension or high blood pressure. They just lose some of that elasticity in the tissue in the blood vessels. So if you take that, already you have the risk for blood vessel disease in older age, and then you also add the complications of diabetes. You actually see in the older population, people tend to have um, more of these diabetic complications than in the younger population. Also, older people don't exercise as much, unfortunately. They usually have other diseases to further complicate diabetes. And so you tend to see diabetic foot ulcers in older, or any type of sort of diabetes complication in those that are older. I would say, I don't know exactly the age or the numbers, unfortunately, but definitely in the elderly population, it's more of an issue.
And it's something that affects both men and women. However, is it prevalent in one over the other?
And if diabetes affects everybody equally, it does not. It doesn't do it. It doesn't affect by gender. There are some studies that say that women have better outcomes just based on lifestyle. Like women are more likely to see their doctors. Women are more likely to follow like medical recommendations, things like that. But that's not the actual disease that's making the difference. That's just the individual. But it doesn't really make a difference by gender either.
Okay. Well, do you have any recommendations in terms of some friendly activities that diabetics can do to avoid a lot of pressure on their feet?
For sure. So, like I said, the most important thing is controlling the blood sugar. And so the best way to do that is just to exercise, go for walks when you can, go to the gym, whatever you're physically capable of doing. Anything that can get your heart rate up will cause your muscles to require more blood and oxygen, and essentially more glucose. It helps you lower your blood glucose that way. In terms of ways to prevent ulcers, it's important to not keep your foot in one particular position for too long. So if you're somebody who sits all day with your feet lifted on the table or something, it's a lot of pressure in one area, and that can lead to poor blood flow to that area. So always kind of keep your feet moving. Um, it's important to wear, like I said, shoes that are good fitting. And I would say if you're not at work or not anywhere that you have to wear closed shoes, just wear slippers or house slippers, things that are comfortable, things that you can take your feet in and out of easily. And a lot of the testing, like the monofilament testing, the checking of the feet, it actually feels kind of good. So you can think of it as like a foot massage as you are checking your feet for the important things, looking for cuts, looking for areas where the skin may be a little bit off colored, because that can be a sign that you're getting poor flow to that area. And you can feel yourself on your feet. If you can't feel the sensation as well when you're giving yourself a nice massage, that may be an indication that you should go to your doctor. If you start to feel any pins and needles in the feet, that's also a sign of neuropathy. And in someone with diabetes, it could be kind of the early signs to diabetic foot disease as well.
Yeah. So one of the interesting things I saw is if you lose hair on your toes and your feet and your lower legs, that you may be at risk for, like, that's something that I don't think anyone would think about, because when folks get older, you might think, oh, I'm losing hair on my legs, I'm losing hair on my toes, especially if they're diabetic, but that could also be a sign.
Right.
Yes. Losing hair, when we have patients who come, especially patients who are younger and we don't expect it, anyone who has sort of poor blood circulation, especially blood circulation in the arteries versus the veins, will lose hair on their legs, and they have very shiny legs,
Mhm.
and that's all often a sign that they have poor circulation to that area. So yeah, it affects those with diabetes and even those without diabetes. Any sort of poor blood flow to an area can kind of present itself as well, because your hair follicles need to get oxygen, they need to get nutrients, and if you don't have good flow to that area, the hair follicles get hungry and they die, and then you lose hair there too.
Yeah.
And also it happens naturally with age. A lot of times we have older people who are actually completely healthy, maybe just hypertension or high blood pressure or something, and naturally we lose hair in areas just because of old age.
Yeah. Have you ever heard of folks who are like have high cholesterol, having diabetic, quote unquote, I guess poor circulation issues that could lead to something similar to a diabetic foot disease?
Oh yeah, I mean diabetes is not the only thing that causes foot disease. Things like peripheral arterial disease, which is basically think of it as a heart attack, but in the vessels of your feet or your legs. So you have some sort of cholesterol deposits that prevent blood flow. Those people have the same risk because it's the same pathology. You don't have good blood flow to an area. If you do get a wound, you're not able to get the cells there to heal it. You have poor healing ulcers. They can become infected. It's the same idea as the diabetic foot disease. It's just that the deposit in the blood vessels in diabetes are usually due to blood sugar, whereas in cholesterol, those deposits are usually a fatty deposit and like cholesterol deposits. So same exact pathology, just different. The way it kind of gets started is different.
Okay.
And are women with gestational diabetes also at risk for diabetic foot disease? Because
That's a good question.
women, yeah, some.
Yeah. So technically, gestational diabetes is a type 2 diabetes. And if it's poorly controlled, it can have similar outcomes. The good thing about gestational diabetes is usually only while you're pregnant. And so the time can be limited to just 9 months. And some women are able to no longer have diabetes afterwards. So you don't often see a lot of these same complications because of time limit. However, it's not uncommon for women to have gestational diabetes that remains after pregnancy, and then she now has type 2 diabetes because of it, and is also now at risk for many of these complications if it's poorly controlled diabetes. But gestational diabetes usually has more outcomes on the size of the child that's born. Usually, women with gestational have diabetes have very large babies because of that. They usually present with more like kidney disease because kidney disease usually presents earlier than foot disease, just because the kidneys have to flush so much of that blood through every second and often have deposits in them a lot faster.
Okay. Well, quite a quick question regarding resources. So the CDC, NIH have all these toolkit for self-management education. And I'm wondering your feedback on that, whether those are actually work, because they do have national ones, they do have local ones within the state as well. So if it does work, obviously we'll promote it for folks to get on the website and, and apply for it. But I'm just curious as to whether you think it's actually beneficial for them to be involved in that.
Yeah, for sure. I don't know exactly about the toolkit, but I know that the CDC, the American Diabetes Association, these are all great resources because of how much they focus on not just the disease, but how it affects populations. So they make everything quite understandable for even someone who has no background in medicine, and they give resources that are based on one's education level. So there's something for everybody to be able to understand what's going on. And a lot of it is created and studied by scientists and doctors, so you know that it's credible. So I would say the CDC is a great resource. The NIH Clinical Center is a great resource. The American Diabetes Association. I even referenced some of their work in my presentation today because they give such good and clear information on diabetes and diabetes management.
Thank you.
Thank you. Dr. Eddie, do we have any questions?
No, I think the people are really enjoying your program. They are understanding everything to the extent that they don't want to ask any questions.
Do we have anyone that we can see that? Okay.
We have some shout out to the good work that Dr. Jiman is doing.
Okay. Well,
I saw my auntie Nanaya. Give a shout out to you, auntie.
Okay.
From Washington.
That's what you call her in church. So, go ahead,
thank
Iman.
you so much, Dr. Jiman, for the excellent presentation. We certainly know that our members gained a lot of information from this discussion today, and we look forward to having you back soon.
Yes.
For sure.
Yes.
Thank you for having me.
Thank you. Thank you for accepting our invitation. I guess hopefully we'll see you soon.
Yes. We hope you have a wonderful evening.
Thank you. You do the same.
Thank you. That was good, Dr. Yvonne. See, I can go away. Dr. Eddie can go away. Just kidding.
No, it's teamwork.
It is teamwork.
It's true. It's true. We can all go away and leave Dr. Yvonne alone.
No, not yet.
Not yet.
Thank you for the support.
You did a great job. And like you said, there's a church program. So Dr. Eddie is going to take me off and then you can close out for the church program. See you behind.
Yes. Well, we hope that you increase your knowledge on diabetic foot disease, who is at risk, and how to prevent and treat the disease. As we heard, foot ulcers affect about 15% of patients with diabetes, and which can lead to a lot of complications. Please, as always, share the link with your friends and your family. As we heard during this presentation, this is a disease that affects both men and women. So do share so they too can benefit from the discussion. Please tune in next week for the rebroadcast of our discussion on endometrial cancer with Dr. Ebony Hoskins, a gynecologic oncologist. And join us on May 24th as we welcome back Dr. Denise Asafo-Ajay for a discussion on male infertility and reproductive health. We would also like to encourage all our viewers to tune in to the EMC Monthly Renewal Program, which is taking place immediately after this program at 8 p.m. Thank you for watching our program. Please feel free to submit your suggestions and or questions to us at emcyouyouandyourhealth@gmail.com. Please continue to stay safe. See you next time. Bye-bye.